In this video, I'm going to discuss having a systematic approach to the analysis and interpretation of myocardial perfusion scintigraphy. You have to have a system. So the first thing you want to do is to check for technical sources of error, as discussed more deeply in the talk on artifacts. This is where you want to identify them before you start making opinions based on error. Given that the scan is diagnostic quality, then you want to attempt to assess for any perfusion defects. That can be done on a visual basis and also on a semi-quantitative basis. There will be ECG gating of the study, and therefore you can assess LV function and regional wall motion abnormalities. Then you can check for additional abnormalities which might clue you in to the presence of balanced ischemia, for instance, transient ischemic dilatation or lung uptake on the raw data during the stress images, so that you're not making the pitfall of identifying no change as no ischemia, but rather balanced ischemia. And then you would synthesize all that information and integrate it into a final report to go back to your referring clinician, which addresses their clinical question and gives them an idea of the diagnosis and the prognosis of their patient. Just to recap technical sources of error, well, the most common is patient motion. Then we might identify soft tissue attenuation from the breast or from the subdiaphragmatic tissues. Commonly there may be extracardiac activity from stomach contents or from the liver. The radiation inside the heart may actually not be optimal. There may be poor counts due to a tissue injection or the slightly incorrect dosing according to BMI of the patient. If you're using a scanner which has got CT for attenuation correction, you need to double check the registration to ensure that you've not incurred new artifacts by the process of that registration. And then to check the ECG, looking for atrial fibrillation, arrhythmias, to judge the quality of the ECG gating such that the ejection fraction that you will quote is not erroneous. So this is the end product of a myocardial perfusion scan, a single display image containing all of the heart in one go, and let me talk you through how this is actually derived and displayed. So you take the heart, orientated along the long axis of the left ventricle, and then slice it up virtually. These are the tomograms. You can cut along the short axis and derive short axis slices the donut from apex through to base. You can cut the heart along the vertical long axis and derive something very much akin to a two-chamber view on echo, except because this is nuclear medicine and the muscle of the atrium is thin, there's no uptake from the atria, therefore you don't see it. And similarly, you can slice the heart horizontally along its long axis, deriving something very akin to a four-chamber view. But again, in SPECT at least, you don't very often see the right ventricle, and the atria, as I've said, do not appear. These three planes can then be displayed all in one go on one sheet, comparing the images achieved at rest and at stress. But with those slices through the apex, through the middle, and the base of the heart, you can then derive the AHA 17 segment model of the heart. This bullseye is a diagram of that, where simply we have splayed out the heart from apex through to the base, such that the apex is in the center of the dartboard, and we have the anterior wall in towards the north, the septal wall towards the west, the inferior wall towards the south, and the lateral wall towards the east. Each segment has names, therefore, the basal anterior versus the mid-anteroseptal versus the apical lateral segment. Each segment has a name, and you can use this also to describe the abnormalities, locate them, and possibly attribute coronary artery supply from where the perfusion defect may be. So to go back to this example, we have short axis images on the top half of the screen, and the stress is displayed on top, and then immediately underneath it is the rest images, and we progress from apex through to base, and here we have got a second row of stress short axis images and the second row of rest short axis images. Then again, stress and rest vertical long axis or two-chamber views, moving from the septal wall through to the lateral wall, and again, stress and rest. And horizontal long axis, moving inferiorly to superiorly, the four-chamber view. And this is a rubidium PET scan, and you can actually see some of the RV uptake much less intense and the RV wall itself thinner due to its reduced muscularity. And again, in this particular image display, it's all on there. The bullseyes are shown, stress and rest bullseyes with the whole heart splayed out for ease of comparison. And on this particular image, the ejection fraction and volume data is also presented. So when you're assessing for myocardial perfusion defects, you want to try and rate them in terms of the extent and in terms of the severity of the defect. So the extent can be described along the lines of segments, and the severity, the depth of the perfusion defect can be described along this semi-quantitative scoring system. A 4-point scale, 0 is normal, 1 is mildly reduced, 2 moderately reduced, 3 severely reduced, and 4 absent tracer, no tracer uptake. The score can be made less inter-observer or intra-observer variable by attributing those levels of mild, moderate, severe to particular degrees of uptake of the heart. So the images of a nuclear cardiology perfusion scan, the images are normalized within each acquisition, the stress and the rest, such that the hottest pixel within the heart is given 100%, and then the uptake is scaled back down. So 70 is a pass mark. So everything above that you will rate as normal, score that 0. Mildly reduced in this schema is 50 to 70%, moderately reduced 30 to 50%, severely reduced 10 to 30%, and absent less than 10% of that uptake. These schema vary according to publication and according to the software that you use to analyze the images, but the principles hold. So what does that mean? That means that you can therefore totalize the uptake, or the perfusion defect rather, between stress and rest, and then also derive a difference. So a normal perfusion scan will score 0 throughout each segment, whereas one that is mildly abnormal a segment might lose a mark. And by determining the change, you can then derive the difference score, which effectively is ischemia, and a rest score, which is effectively a measure of infarction. I think this is illustrated better if you go through a couple of cases. So here's one, a 57-year-old lady. The recent cardiac CT that she had step artifacts and was deemed non-diagnostic, and therefore she was referred to a myocardial perfusion scan. Her original presentation was one of left arm, jaw, chest discomfort, last less than 5 minutes, not on exertion. The question originally was, is this atypical angina? Risk factors include hypertension and raised cholesterol. And the question was query coronary artery disease. The CT scan showed an Agatston score of 2, and specifically in the report they said there was artifact across the diagonal, but there was no other coronary artery obstruction. So the question today for the MPS is there reversible ischemia? The patient's BMI was 30 and her bra size is 38D. So we review the raw data. We have the stress state on the left-hand side and the rest state on the right-hand side. The intensity is scaled off the hottest pixel in the image. So on the stress data, that's actually the gallbladder, and at the bottom left, which contains excreted tracer. There's much more hepatic uptake, but also biliary uptake on the rest images on the right-hand side. Here we can judge for motion. Here we can possibly judge for the size of the patient. We can look for lung uptake, and we can look for adequacy of stress imaging by a reduction of splenic uptake. There's a difference here between the spleen on the stress scan and the spleen on the rest scan, and that variation is due to the splenic constriction you get, vasoconstriction you get during adenosine versus myocardial vasodilatation due to the different receptors that the smooth muscle cells in the respective vasculature have. The images are reorientated along the axes as I've described, short axes, vertical long axis, horizontal long axis, both for stress and for rest, and we can check that these are matched up and aligned similarly together, such that we don't have any offsets. and then the images are displayed for comparison. Stress on the top row, rest on the bottom row. In this display set, we have no bullseyes, short axis on the top, horizontal long axis in the middle, and vertical long axis on the bottom. And the game here in nuclear cardiology is to spot the difference. Is there a difference? Because any difference we will attribute to ischemia. There's a reduction of stress, which improves at rest. So there's nothing glaring in this scan, but if we were to look closely towards the apex on the horizontal long axis in the middle of the screen and comparing that with the rest just below, the apex is a little bit thinner, a little bit more purple, and it plumps up and becomes a little bit more orange. And if you cross-correlate that with the vertical long axes, I think you can appreciate that in the middle of the screen on the bottom row, the apex, maybe the apical anterior segment, a little bit purple, a little bit thinner, whereas it's a little bit brighter, a little bit plumper, more orange on the rest images immediately beneath. If we display that as a bullseye image, stress on the top in the center, rest immediately below, you can see there that the apex is a little bit purple on this colours lookup table, and on rest it fills in. And if we look at the difference image, which is below, the apex of the heart is highlighted as being a difference. Just to the right hand side there is a 3D representation of the LV, and again the apex is a bit purple, but on the rest image, the 3D volume rendered image, it looks much more homogeneous. So there's a mild reduction in the apex, which improves at rest. Now the interpretation of this may be that there is mild limited ischemia. However, we've noticed that she has got a large chest, and it's more likely, especially as we know the coronary anatomy from the cardiac CT, that this is actually changing soft tissue breast attenuation due to different positioning during the stress and rest exams, causing this change. So the clinical report here is that there's a mild reversible change in the apex, more likely due to the changing soft tissue breast attenuation. Diagonal territory demonstrates no ischemia. The coronary artery disease that was seen on CT is not flow limiting. The second case, this time a 72-year-old man, 9-month history, chest tightness. It's relieved by GTN. He has a hiatus hernia. Is that to blame, or is this a cardiac cause? His BMI, similar, 31. Patient is stressed and images are required, and then the patient comes back for a rest study, and these are the raw data from both. Stress on the left, rest on the right. Again, you see the hepatobiliary excretion, gallbladder uptake, and tracer has gone into the duodenum and into the small bowel on both. You can appreciate that his arms are down by his side, and ideally we would put the patient's arms up above their head if they could do so, but very often people find that tricky. But it just means you have more attenuating tissue by the patient's torso if the arms are down by their side. We look for motion, we look for lung uptake, we look for uptake adjacent to the heart in the liver or in the stomach. This is the slice reorientated data, and it shows on the stress images that actually the gut uptake is overlapping with the inferior wall, less so on the rest images on the right hand side of the panel. But I think immediately you can appreciate that there's a problem in the lateral wall of the heart. If we look at the whole data set, and here the images have been coned down to just include the heart, so that the uptake of the liver is excluded off the inferior wall. You can see that there's a severe reduction laterally from apical lateral to basal segments, extending essentially on the short axis views the entire length of the heart, which on rest normalizes. So there's lateral ischemia. If you look at the bullseye picture, you can get an idea of exactly how much the heart is affected, and you could even use a segmental approach and say, well, that's possibly 2/5 of the heart, and maybe 20% ischemia based on just by eyeballing it. Or you can overlay the percentage or relative uptake according to the hottest pixel. Here the hottest pixel is somewhere in the apical septal segment. All the uptake is scaled back at stress and at rest, and that you can derive a scoring system based on that mild, moderate, severe scoring. And the computer here is saying that there's more of the order of above 10% ischemia. So this patient has got, in the report, would be lateral ischemia, at least moderate. And there is ECG gating, and we can look at regional wall motion abnormalities and the left ventricular function. And here the ejection fraction is at 59% at rest. EDV 57, and there's possibly some mild inferior lateral hypokinesis. But on the basis of this perfusion scan, the patient was sent to the cath lab and have selected images from his angiogram showing a very tight left mainstem disease. On the spider view, there's also circumflex disease, giving him that lateral ischemia, and the dominant right coronary artery not obstructed. So subsequent to this, because of the left mainstem and the circumflex disease, this patient went to coronary artery bypass surgery. So just to recap the system, look for technical sources of error, counts, attenuation, motion, problems with the ECG, and then if you're happy the images are matched up and scaled correctly, make a visual assessment of is there any difference between stress and rest, and then perform the semi-quantitative assessment of how profound that perfusion defect is. Add in regional and LV function globally, and then look for additional abnormalities that might clue you in that a normal scan may actually have additional ischemia. And again, synthesize that data, incorporate it all into a clinical report which answers the clinical question. With that, thank you.